All right, so what we're going to do this morning is a CPR AED first aid challenge course, and then we're going to review some of the medical standards for the jail. Okay, things that's important medically you have to review on an annual basis. First off, CPR first aid AED compared to the jail to the outside world is no different. The only difference is, and when they come to jail, they sign a consent to treat form. So we have to take care of them. On the street, you have to gain, as a citizen, you have to gain permission to treat them. Okay? So you have to ask them if you can treat them, tell them who you are. If they tell you no, do not touch them, because they can sue you because you will not be covered under Good Samaritan law at that point. However, if they go unconscious, at that point, then you can use implied consent and treat them. Okay? So the first video I'm going to show you is just reducing the risk of infection. Real simple video. I just want to make sure everybody knows how to properly remove rubber gloves. Believe it or not, there is a proper technique to do it.
For proper glove removal, first, pinch the palm side of one glove on the outside near your wrist. Pull the glove toward your fingertips, turning it inside out as you pull it off your hand. Hold the glove in the palm of your other, still gloved hand. Carefully slip 2 fingers under the wrist of the other glove. Avoid touching the outside of the glove. Pull the glove toward your fingertips, turning it inside out as you pull it off your hand. The other glove is now contained inside. Dispose of the gloves properly and wash your hands.
It's a pretty simple video, but believe it or not, I teach Corrections Academy, and I make sure no one's allergic to ketchup first of all. But then we put the gloves on and smear ketchup all over their hands and make them try to get them off as simulating blood or other bodily fluids. You'd be amazed how much people get on them trying to get the gloves off. This is a very lengthy video. It walks you through every step as to treating somebody in the real world. So it's the check, call, care.
An emergency can be stressful, but you can take steps to help a person in any emergency situation, from cardiac arrest to choking to life-threatening bleeding. The idea is that you don't have to think about what the specific emergency is. You just need to remember 3 steps and you'll be prepared to help. The 3 steps are check, call, and care. The first step is check. This step includes checking for safety, obtaining consent, and checking the ill or injured person. Remember, safety first. You must check the scene to make sure it is safe before you go help the person. Here are some examples. Would you enter a burning building without training? No. Is it safe to cross downed power lines? No. So just check for safety and don't enter an unsafe scene. Instead, immediately call 911 or tell someone to do so. After checking the scene for safety, check the person and obtain consent. Checking the person includes forming an initial impression, then conducting a more thorough check. You should obtain consent after you have formed an initial impression, but before you touch the person to complete your check. So let's address consent first. To obtain consent, tell the person who you are and what you plan to do. This is as simple as saying, "My name is Joanne and I'm trained in first aid. I'm going to check you and help you based on my training." Then continue helping them unless they say they don't want your help. In that case, you can't check or care for them. But you can call 911 if you think they need help. A person who appears unresponsive or mentally altered, for example, they're confused or disoriented, may not be able to give consent. In these situations, consent is implied under the law. Basically, the law assumes the person would give consent if they could. So, go ahead and help them. And now let's address checking the person. You must check the person to determine what is wrong and what you should do next. You can usually get an idea of what's going on with the person as you approach them. This is called the initial impression. As you form an initial impression, ask yourself, does the person appear unresponsive? Do they seem to be breathing? Are they bleeding a lot? Do they look sick or hurt? When you reach the person, you have a decision to make based on whether the person appears unresponsive, is experiencing a life-threatening emergency, or has a non-life-threatening injury or illness. It's a lot to take in, so let's break it down. Okay, if the person appears unresponsive during the initial impression, you need to check them for responsiveness. At the same time, you should check for breathing, life-threatening bleeding, and any other life-threatening condition that you might not have seen during the initial impression. To check for responsiveness, quickly do the shout, tap, shout sequence. Simply shout the person's name, tap the person on their shoulder or arm, and shout again.
Paula, you okay? Paula?
If the person does not respond to you in any way, such as by moving, opening their eyes, or moaning, they're unresponsive. You can check for breathing while checking for responsiveness. First, make sure the person is face up. If they are face down, roll them onto their back, taking care not to create or worsen an injury. Then look to see if the person's chest is rising and falling. Normal breathing is quiet, regular, and effortless. Agonal breaths, or isolated or infrequent gasps, are not considered normal breathing. To check for life-threatening bleeding or other life-threatening conditions, quickly scan down the person's body looking for blood or other signs and symptoms.
She's not responding or even breathing. I don't see any blood though.
Checking for responsiveness, breathing, life-threatening bleeding, and other life-threatening conditions might seem like a lot to do at once. But remember, it is a quick check that should take no more than 5 to 10 seconds. Now, if at any time you determine the person is experiencing a life-threatening emergency, that is, they are unresponsive, responsive but not fully awake, not breathing, experiencing life-threatening bleeding, or they have another life-threatening condition, stop the check step and immediately move to the call step. Then give care according to your level of training. In addition, you should continue your check, as appropriate, to determine if additional care is needed. If your initial check reveals that they are experiencing a non-life-threatening illness or injury, you will also continue your check of the person to see if they have conditions that may require care. To continue your check, first ask the person questions about their health and what is wrong, and then check them for signs of illness or injury. So, how do you remember what questions to ask? You can use SAM to help you remember. What does SAM stand for? Signs and symptoms, allergies, medications, and medical conditions. Simple to remember, right? You would ask the person questions like, what is bothering you? Do you have any allergies? Do you take any medications? Do you have any medical conditions? That's it. All you have to do is remember SAM, signs and symptoms, allergies, medications, and medical conditions. Very simple, very straightforward. Next, you should do a quick focus check of the person. What you check is based on what the person has told you, how they are acting, and what you see. So if the person tells you that their arm hurts, focus your check there and look for signs of an injury. Or if the person is crying and grimacing in pain, and you see some blood on the ground that seems to be coming from underneath their leg, carefully check for an injury to their leg or back. The person may have multiple signs of an injury or illness in different areas of their body. For example, they may report pain in their stomach and pain in their hip. In this case, be sure to do a focus check in each of these areas. The reason you should ask questions and do a focus check is because as time goes on, the person may be less able to say things. You may gather information that others may not be able to gather later. So after check, the next step is call. Of course, you'll want to care for the person right away, but first you want to make sure other help is on its way if necessary, and that you have the equipment you need to help. Therefore, call may include calling 911 to activate emergency medical services and getting equipment such as an AED, a first aid kit, and a bleeding control kit. Depending on the circumstances, you can either send someone to do this or do it yourself. Just a quick note. Throughout the course, we will refer to 911 as the emergency number to call. In most areas, 911 will work. However, if you live or work in an area without 911, use the local designated emergency number. Also, if your facility uses an internal number to activate an emergency action plan in EMS, use that number. Okay, so based on the type of injury or illness the person has, you can decide whether or not you need to call 911. If you didn't find anything, or the person only has a minor injury or illness, you may not need to call 911 for help. This may be something that you can handle on your own using your first aid skills and guidance from the Red Cross First Aid app. In this case, get or have someone get a first aid kit and move to care. However, if you do need to call 911, either make the call yourself or ask someone at the scene to do it. Using a cell phone to call for help is nice, especially when you put it on speakerphone. EMS dispatchers are often trained to give you guidance. If you ask someone to make the call, always pick someone specific. If you just yell, "Someone, call 911," you won't know for sure if it's going to get done. So instead, look directly at one person and say, "You, call 911." That way you know who made the call and that help is on the way. The final step is to give care according to the conditions that you find and your level of knowledge and training. Throughout the course, we will teach specific action steps that you can take to give care for life-threatening emergencies. You should always follow these general guidelines. Give care consistent with your knowledge and training. Offer to assist the person with medication administration if needed. Help the person rest in the most comfortable position. Keep the person from getting chilled or overheated. Reassure the person by telling them that you will help and that EMS personnel has been called if appropriate. Continue to watch for changes in the person's condition, including breathing and level of responsiveness. No matter what the emergency is, the check, call, care approach will get you through it. Throughout this course, we'll give you key information that will help you save a life. But above all else, we want you to remember these 3 steps. Check, call, care. In every skill we teach you, we'll keep going through these steps. That way, in an emergency, you can revert to something simple that you can easily remember. This will help you remain calm, feel confident, and make you more successful at helping to save someone's life.
Okay, long video, like I said, but to explain check, call, care. You can kind of use the same thing in the jail. I mean, you're obviously not going to be, one person's not going to run into a cell by himself without backup, correct? So you're checking there to make sure it's secure. I don't know if you have a emergency response plan in place, but if you do, that kind of takes care of the call part of it. Some jails do have. I went in and set up an emergency response, how we react to certain things. So everybody knows what they're doing. Everybody's not running helter-skelter. If that's something you want, we can do that at some point. It kind of eliminates the call part because everybody knows what they're doing. Somebody's already responsible. And then care, obviously, we're as basic first aid, we're putting Band-Aids on. We're stopping bleeding. We're doing the minimal stuff until EMS arrive to take them out of the building. So just remember that. The recovery position, I'll just make sure everybody knows how to place somebody in the recovery position. Anytime there's an emergency situation, they've had an injury, we're going to put them in the recovery position if we don't suspect head, neck, or back injuries. Okay? Simply because if they vomit, it will run out of their throat, run out of their mouth, not down into their lungs and cause other problems. If they're responsive enough to understand what you're saying and they have no injuries, you can just set them against the wall, let them sit comfortably. But if you have to put them in the recovery position, this is the easiest way to do it.
It is important to turn a person who is unresponsive but breathing or is responsive but not fully awake onto their side to lower the risk for choking and aspiration. Turning the person toward yourself rather than away from yourself allows for more control over the movement and helps you monitor the person's airway. To put a person in the recovery position, extend their arm closest to you above their head. Now roll the person toward you onto their side so that their head rests on their extended arm. Finally, bend both of their knees like this to stabilize their body.
Pretty simple.
Caring for a responsive choking adult consists of 5 back blows followed by 5 abdominal thrusts. Watch as Richard and I demonstrate this care for a choking adult. To perform back blows, first position yourself to the side and slightly behind the choking person. Then place one arm diagonally across the person's chest and bend them at the waist so that their upper body is as parallel to the ground as possible, like this. This position helps remove the object and allows you to brace yourself if the person becomes unresponsive. At this point, firmly strike the person between the shoulder blades with the heel of your hand. Now, I'll simulate 5 back blows, but I will not use full force as I would if Richard were actually choking. 1, 2, 3, 4, 5. After back blows, if they are unable to call for speak, give abdominal thrusts. First, find the person's navel with 2 fingers. Then, move behind the person and place your front foot between the person's feet with your knees slightly bent to provide balance and stability, like this. Next, with your other hand, make a fist and place your thumb side against the person's stomach right above your fingers. Finally, take your first hand and cover your fist with that hand. Then pull inward and upward to give an abdominal thrust. Now, I'll simulate 5 abdominal thrusts. Again, I'm not going to use full force. 1, 2, 3, 4, 5. Continue giving sets of 5 back blows and 5 abdominal thrusts until the person can call for speak or the person becomes unresponsive. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. If a person is pregnant, too large for you to stand behind and reach around, or if the person is in a wheelchair, you may need to give chest thrusts. Ready, Marla?
Yes.
To give chest thrusts for a responsive person, make a fist with one hand and place the thumb side of your fist in the center of the person's chest. Grab your fist with the other hand and give quick thrusts into the chest. 1, 2, 3, 4, 5. It is important to know that back blows, abdominal thrusts, and chest thrusts are all equally effective for responsive choking, but it may take more than one technique to clear the airway.
Seth, can I use you as a body for a second? I just want to explain to everybody one thing. You've seen how they show you off to the side and you're bending him over, holding him here. What happens if he goes out right now? He's falling face first, because are you really going to stop him with one arm? So if in any way possible you can feel comfortable enough to get that leg in between their leg and still do the back blows, you got your body against him, your leg against him, your arm around him. If he starts to go, you may be able to grab him, pull him back to you, get your arms under him, get him to the ground, okay? I just wanted to show you that, because if it's a very big fella, or it could be a small person, if you don't have enough strength in that arm, they're going to hit the floor. And then you have other emergencies. He probably knocked himself out, cut himself. With abdominal or back blows and abdominal thrust, we only do that if they're not getting any wind in at all, any air in at all, okay? If you can hear some sort of noise coming out, they're able to cough, speak at all, we don't want to resort to that because we may dislodge it and make it go deeper, okay? However, if we don't get it out, there's a good chance they're going to go unconscious. Okay? When they go unconscious, we get them to the floor, and then we're going to start CPR slightly modified version. Okay? So you're going to start with chest compressions, and then if we're doing mouth to mouth, you would open the mouth, look to see if you see an object before you would do mouth to mouth, because again, the air could blow it down deeper as well. If you don't see an object, just go back to compressions. Okay? Because we don't want to force it. We already know they're choking. We don't want to make it go any deeper. A couple other modifications. If it is a pregnant female, we're not going to give abdominal thrust. We're going to give chest compressions from behind. Same way, middle of chest compressions. If it's somebody you can't get your arms around their stomach, we'll also give chest compressions. Okay? If it's an infant, we're going to do it a whole lot different. We're going to put them in our arm, supporting their neck, hold their head downward to the floor. You're still going to give back blows. You're going to roll them over, holding them in your other hand, and you're going to give chest compressions as well. Simply, we're let gravity help us and let it come to the roof of the mouth, because they definitely do not know not to swallow it, and they will. Okay? But again, we're only going to do that in a situation where they're not getting any air in at all. If they're getting air in at all, just encourage them to keep coughing, try to get it up. But eventually, if they don't, there's a good chance they're going to go unresponsive.
A stroke occurs when blood flow to part of the brain is interrupted by a blood clot or by bleeding from a vessel, resulting in the death of brain cells. Effects throughout the body are possible, including paralysis, loss of speech, problems with memory, and trouble with thinking. Strokes can cause permanent damage, but with quick action, sometimes the damage can be stopped or reversed. The fast mnemonic can help you easily recognize the common signs of stroke and give EMS professionals crucial life-saving information. Signs that indicate possible stroke include facial weakness on one side of the body, arm weakness or grip weakness on one side of the body, speech disturbance. If you think that a person is having or has had a stroke, call 911 and get equipment immediately, or tell someone to do so. After calling 911, note the time of when the signs and symptoms first started. If you do not know when the signs and symptoms started, note the last time the person was known to be well. This is important information to give to EMS professionals. Some medications and procedures used to treat stroke are only effective within a certain time frame after the onset of signs and symptoms. Then, stay with the person and provide reassurance until help arrives. Continue to check for responsiveness and breathing. If the person is responsive but not fully awake, drooling, or having trouble swallowing, put them in the recovery position. Then, monitor the person's condition until EMS professionals arrive and begin their care.
The most important one of those, if you recognize a stroke, is the time, because that'll depend on what medications they give them when they get to the hospital. And they are right. The modern medicine has advanced so much that a lot of times people have no ill effects if they get the medicine quick enough.
A person with asthma should be able to let you know if they are having an asthma attack. Signs and symptoms of an asthma attack include wheezing or coughing, rapid, shallow breathing or trouble breathing, being unable to talk without stopping for a breath in between every few words, anxiety and fear, and sweating. For a person who is experiencing an asthma attack, quick relief medication, such as albuterol, can help quickly open their airways and allow easier air passage. This medication is delivered via an inhaler. You may assist with administering this medication. Follow the general care steps for assisting with medication administration. Then, shake the inhaler, remove the mouthpiece cover, and attach a spacing device if necessary. Give the device to them and encourage them to use it as directed by their healthcare provider. Finally, be aware that more than one dose of medication may be needed to stop the asthma attack. The medication may be repeated after 10 to 15 minutes.
Red Cross says that you're not supposed to administer medication unless you have a class to administer medication. That's why they say to allow them to do it themselves. Most people that have asthma attacks have had them many a time, so they understand how to use the inhaler. If there be a chance where they're completely freaking out and they don't know how to do it, you know, try to do your best to get it in their mouth. I don't know if you've ever seen people in jail take inhalers. It's usually and they're done, right? That doesn't do them any good. Okay, put it in their mouth, shake it up, put it in their mouth, push the button down, tell them take a deep breath. Okay, hold it for about 10 seconds is what you're supposed to do, and then administer the second dose. So that's the important thing, is to make sure they get the medicine into them.
Anaphylaxis is a life-threatening allergic reaction that can cause shock and affect the person's ability to breathe. Signs and symptoms of anaphylaxis include history of an allergy, signs of an allergic reaction, swelling of the face, neck, tongue, or lips, trouble breathing, shock, and a change in responsiveness. Epinephrine can help slow or stop the effects of anaphylaxis. People known to have an allergy may carry an epinephrine auto-injector. There are several different epinephrine auto-injectors on the market. You may assist the person or family member with this medication. Follow the general care steps for assisting with medication administration, then give them the epinephrine auto-injector. Hold the person's leg firmly to limit movement. Encourage them to use the epinephrine auto-injector as directed by their healthcare provider. And finally, massage or have the person massage the injection area for 10 seconds. If the person is still having signs and symptoms 5 to 10 minutes after administering the first dose and EMS has not arrived, help the person to administer a second dose.
Okay, now I'm going to tell you that if somebody is in anaphylactic shock, they're probably not going to be able to give themselves an injection, okay? You've probably seen somebody have a bee sting, eat peanuts, peanut butter, chocolate, iodine, you know, like seafood. It is a serious life-threatening condition. If they do have an EpiPen, it'll look sort of like this. It has a window in it that you can see the fluid. They say if it's cloudy, you shouldn't use it because it might not be quite as effective. If that's the only one they have and it's cloudy, myself, I'm going to use it because it might be the only thing that truly saves their life. But it's real easy to use. Grab it here, you remove the end, hold it tight, right through the pants, into the thigh is the best place. Again, hold it for about 10 seconds. When you release it, the needle won't be exposed, so you can't expose yourself. If in 5 or 10 minutes they haven't, hopefully they have, because 5 or 10 minutes might be too late if their throat swells shut and they can't breathe. But if they have a second dose, you can by all means administer it. If you give somebody an EpiPen, I recommend 100% of the time you send them to the hospital, whether it's in the jail or not. You did have some of these here when I was here in December, because you will have people come in that doesn't tell you that they have allergies, and they'll eat the peanut butter on purpose so they can get a trip to the hospital. I've seen it happen. So if you don't know where these are and you happen to be working in a jail, I know I've seen April work in the jail a couple of times, so you might want to make sure you get them. They usually come in a double pack and they're about $350. They usually have a shelf life of a year and a half.
A person having a heart attack may have persistent chest pain, pressure, or squeezing, or isolated unexplained discomfort in the arms, neck, jaw, back, or stomach. In addition to these classic signs and symptoms, a person may have more general signs and symptoms, including dizziness or lightheadedness, trouble breathing, including shortness of breath, pale gray or bluish skin, nausea, vomiting, or diarrhea, extreme fatigue, sweating, a feeling of anxiety or impending doom, and unresponsiveness. Although men often have the classic signs and symptoms of a heart attack, women may have more subtle signs and symptoms. The classic signs and symptoms may not be the most obvious, or they may experience the signs and symptoms of heart attack differently than men do. For example, in women, the classic signs of a heart attack may be milder or accompanied by more of the general signs and symptoms. If you think a person is having a heart attack, after calling 911 and getting an AED and a first aid kit, assist them with aspirin to help minimize the effects of the heart attack. First, make sure the person is awake, can follow simple commands, and can chew and swallow. Then follow the general care steps for assisting with medication administration. Next, give the person 2 to 4 81 milligram low-dose aspirin tablets. So that's a total of 162 to 324 milligrams. Or give one 325 milligram regular strength aspirin tablet, which can be enteric-coated or non-enteric-coated. Finally, tell the person to chew the aspirin completely. If the person takes a prescribed medication for chest pain, such as nitroglycerin, assist them with it.
If somebody's having the classic signs of a heart attack and you give them the aspirin, does anybody know why we do that? It thins the blood, allows the heart to at least help get the blood out a little better. The classic signs are easy to tell. Some people will have a heart attack with not even an elevated blood pressure. So if you suspect there's something going on, the best thing to do would be, if you're out on the street, to call a squad, let them figure it out. If it's in the jail, if medical's in the building anytime that this is going on, make sure they check them. But I always lean on the side of caution so we don't have, a death in custody. But this next one, if you do work in a jail very long, there's a good chance you've already given this or you will have to give this.
Opioids are drugs that are prescribed to reduce pain. The effectiveness of opioid drugs has led to their widespread use, but we have also seen misuse and addiction, fueling what is being called the opioid epidemic. Signs and symptoms of opioid overdose include evidence of opioid use and decreased breathing effort, for example, breathing slowly and perhaps only a few times a minute, unresponsiveness, bluish or grayish colored skin, and cardiac arrest. If the person with a suspected opioid overdose is unresponsive and not breathing, immediately begin CPR or compression-only CPR, depending on your training. If there is a family member or person trained, they can administer naloxone. You may assist a family member with administering naloxone to temporarily reverse the effects of opioids. Naloxone may be given via the nose, using a nasal atomizer or nasal spray.
So, real quick on Narcan. Again, if you suspect an opioid overdose, the first thing to do, they told you the classic signs, is hit them with a dose of Narcan, okay? Pick a nostril, put it in their nostril, push the plunger, okay? You don't have to shove it into their brain. I've seen people take the Narcan out and people's nose will be bleeding and all that stuff. You don't need to shove it in that far. Just get it in a good fit, push the button. If every 2 to 3 minutes they don't respond to it, grab another one, hit the other nostril. You rotate nostrils every 2 to 3 minutes. How many doses do we give? I was told once down here that your EMS told you can only give 2 doses before they arrive. Okay?
They do say that.
Okay. If you only give, unless they're within a couple of minutes from here, you're going to have a lot of death in custodies. Okay? So that's between you and the EMS. I tell you, you give it as many as it takes to revive them. Okay? I've seen myself personally 6 and 7, sometimes 8 doses before they respond, depending on what their drugs are cut with. So that's a decision you have to make on your own. I'm going to continue to feed it until they come to or EMS arrive. So naloxone, also known as Narcan, is a medication that blocks the effects of opioid in reverse overdose. So what happens is they can't breathe. It slows everything down. Okay? They go unresponsive. The Narcan reverses that. If we give Narcan to somebody, unless you have a policy that states otherwise, 100% of the time they should be transported to the hospital. Because when that Narcan wears off, they're going to go right back into the same situation possibly that they were in before. Okay? What was I going to say? Have you ever given it, Seth?
Narcan?
Mm-hmm.
Oh, a number of times.
I figured. You? Anybody else ever given it? I've seen a couple. The 2 biggest things I've seen when they come to is they want to fight everybody in the room, or they just open their eyes and they somewhat chill. They don't really know what went on. I did it in the jail one time in Muskingum County, and the guy wanted to fight everybody because they killed his buzz. That's what he said to him. So, But Narcan is a life-saving measure. Some places, I know Youngstown's one, they used to have it in vending machines that you could purchase. One time at Muskingum County, they called me to booking because some woman had 17 doses of Narcan in her purse. They said, why would somebody carry that much? I said, well, the easy way is to ask her, right? So I did, and you know what she told me? They have Narcan parties. Ever heard of that? One person stays sober, and if anybody goes out, you're responsible to give them the Narcan. Now that's what I'm going to do in a group full of drug addicts, is trust one of them, right? But they do stuff like that, so. And if it, believe me, stuff gets in a jail, we've had it happen many a times. Somebody brings fentanyl into your jail, and they get back to the cell with it, they're going to most likely share it with 3 or 4 people. So if one goes down, there's probably 3 or 4 that's going to go down. And probably the ones that's been in jail for a period of time are going to be affected more so because they haven't had drugs for a while. So they'll be the most likely ones to go out quicker.
Diabetes is a condition that makes it difficult for the body to process glucose, commonly known as sugar. There are 2 types of diabetic emergencies: when the person's blood glucose or sugar is too high, and when their blood glucose is too low. If the blood glucose is too low, then giving sugar can be life-saving. If you don't know whether the person's blood glucose is low or high, it's good to give some sugar. The sugar you give will be life-saving if their blood glucose is low, and will not have a major negative impact if their blood glucose is high. Signs and symptoms of a diabetic emergency include trouble breathing, fast or deep breathing, feeling weak or different, sweating, and a fast heartbeat. If the person is known to have diabetes and is having a diabetic emergency or requests some form of sugar, you can help by giving sugar. First, make sure the person is awake, can follow simple commands, and can chew and swallow. Then follow the general care steps for assisting with medication administration. Finally, give the adult 20 grams of sugar. If possible, give glucose tablets, liquid, or gel. However, other acceptable forms of sugar include 7 ounces of orange juice, 14 ounces of milk, or candy with fructose or sucrose, such as 20 to 25 Skittles, 2 strips of fruit rolls, or 10 to 20 jelly beans.
You remember that, right? 10, 20 jelly beans. Listen, the basis of it is, if you suspect it's a diabetic emergency, even if you don't have a glucometer, and you give them some sort of sugar, as long as they're responsive enough to be able to eat it, swallow it. There are injectable that you can use as well. If it is already high and you give them sugar, all you're going to do is make it a little bit higher. But if it is low, it's definitely going to bring them up. The one thing I always say when I'm doing CPR for a jail is, if you're working the floor and they bring somebody in and says they're drunk, don't always believe 100% that there's nothing else going on, because diabetes masks some of the same symptoms. They can lay in your cell and go into ketoacidosis and become a real emergency. So try to be an investigator and find out exactly what's going on. It's hard to get answers out of them, I understand that, but the good thing is, when you work in a jail, most of the time you see these people over and over and over, so you might already know they're diabetic, so you lean on, taking care of that situation. Bleeding, I'm not going to show you a video on it. If somebody has a deep laceration with uncontrolled bleeding, we're going to apply direct pressure to the site with, they say, a clean, sterile dressing. If we don't have that, we're going to use a shirt off our back or whatever we have. Apply direct pressure. If it bleeds through that dressing, leave that dressing on, apply another dressing to the top of it until we get the bleeding stopped. Once we get the bleeding stopped, we will not remove the original dressing because we don't want to take away the clotting that's already started, and we'll secure that dressing in place. If it's more so a severe emergency, which means that there's an arterial bleed, then a tourniquet would have to be placed, or they're going to bleed out in a few minutes and die. Okay? If you put on a tourniquet, Red Cross tells you you should go 2 to 3 inches above the wound. I'm going to tell you, go as high and tight as you possibly can. Tighten it down as tight as you can. Lock it in place. Put the time on it when you put it on. If it starts to bleed through again, then just add another tourniquet, blow it. Don't ever remove the original.
A burn is a type of wound that can be caused by contact with heat, chemicals, radiation, or electricity. Burned areas can appear red, brown, black, or white. You may see swelling, blisters, or both. Burns range in severity from minor to life-threatening. Burns requiring immediate medical attention include burns that extend through deeper layers of skin or the fat, muscle, or bone underneath. Burns that cover more than one body part or a large percentage of the person's total body surface area. Burns that affect areas that could impair a person's function or their ability to breathe, such as burns on the face, hands, feet, joints, or groin. Inhalation burns. Burns caused by electricity, chemicals, radiation, or an explosion. Or burns in people with medical conditions or other injuries. Also, if the person is older, immediate medical attention should be obtained. After completing your check and call steps, give care for the person with a burn according to your level of training. To give care, cool the burn under clean, cool running water. Cool the burn as soon as possible and for at least 10 minutes, but ideally 20 minutes. If clean, cool running water is not available, you can use clean, lukewarm water or apply a cool or cold compress. Never use ice water, or a freezing compress to cool a burn. Finally, leave the burn uncovered. EMS personnel will give care when they arrive. However, if EMS is delayed or you are in a remote location, cover the burn loosely with a sterile dressing. If a sterile dressing is not available, a clean dressing or even plastic wrap may be used to cover the burn.
If somebody is burnt, like the picture they showed, and you have to cover it with the dressing, put it on loosely. Once you put it on, don't remove it, because any blistering that's occurred is going to come off with it, and you're going to open up the skin for infection. Obviously, if it's a large percentage of the body, it's kind of hard to cover. So just remember, don't take it off once you start.
Traumatic accidents, such as falling from a height, getting thrown from a vehicle, or sustaining a blow to the head, can cause head, neck, and spinal injuries. Signs and symptoms that might cause you to suspect a head, neck, or spinal injury include mechanism of injury, which means the method by which the injury occurred, a change in behavior or mental status, for example, unresponsiveness, confusion, stumbling, repeatedly asking the same questions, memory loss, nausea or vomiting, or speech problems, head, neck, or back pain or visible injury, a partial or complete loss of sensation or movement in part of the body, seizures, and the inability to do activities that the person could previously do, such as walking. After completing your check and call steps, provide care for the person with a head, neck, or spinal injury according to your level of training. While you're waiting for EMS personnel to arrive, have the person remain in the position in which they were found, unless you need to move them to give CPR or control bleeding. Also, help maintain the person's body temperature, and, based on your level of training, care for any other injuries that may be present. A concussion is a traumatic brain injury that alters the way the brain functions. Concussions can occur anytime a person experiences a bump, blow, or jolt that results in rapid movement of the brain within the head. Signs and symptoms of a concussion include dizziness, loss of consciousness, headache, confusion, blurred and/or double vision, nausea, vomiting, seizures, memory loss, and the inability to do activities that the person could previously do. As always, complete your check step. If you think a person has a concussion, advise them to stop their activity. If you see signs and symptoms of concussion in a person, call 911 and get the equipment or tell someone to do so. Then give care for a person with a concussion according to your level of training. First aid care for concussion is the same as for all types of injuries to the body. While you are waiting for EMS personnel to arrive, have the person rest without moving. Help maintain their body temperature and, based on your level of training, care for any other injuries that may be present. If, for any reason, EMS was not called, the person should follow up with a healthcare provider as soon as possible for a full evaluation.
If you suspect head, neck, or back injuries, only move them in an absolute emergency that you have to move them, okay? Simply because if there is something wrong, you could make it worse by moving them. If you do have to move them, try to move them in the position you found them. What I'm saying, if the head's clear over here, we don't want to straighten it up to move them, okay? So as long as there's not an emergency situation going on that creates where you have to move them, leave them in the position you found them until EMS arrive. I've done that in the jail many a times. Guy's face down on the floor, had a little bit of bleeding. I was able to stop the bleeding, but I did not allow him to move until EMS arrived. I did put a C-collar on him, but I'm not going to teach you how to put a C-collar on him. But you just don't want to put yourself in that situation. If you do have to move them because emergency arises, move them by all means. But just remember, you may paralyze them. It's better than the ultimate, right? So I'll talk about heat stroke. Heat stroke is, so any heat-related emergencies is a 3-step progression. Friday night football game, you see a guy bending over, getting cramps, getting stretched out. It starts with heat cramps, then it progresses to heat exhaustion, and then it progresses to heat stroke. When it gets to the point of heat stroke, something needs to be done emergently, as in an emergency. Their body temperature is elevated way above where it's supposed to be, so you need to cool the body as quick as possible. They will tell you, pack them in ice, submerge them in water, from the neck down, wrap towels around them, whatever, to decrease their body temperature. The most important thing is to catch it early so we don't progress to a heat stroke. Hypothermia, obviously, is the complete opposite. Get them out of the source of the cold, cover them with blankets, put toboggans on them, get them in front of a heater, whatever it is. Just don't physically be rubbing on the skin or nothing like that, because it's already frostbit. You'll peel the skin off of them, okay? And poison. The number one thing you can do with poison, if you suspected somebody drank something, swallowed something, come in contact with something, if you're out on the street, obviously you're not going to have an MSDS sheet, but in the jail you're supposed to. It's a material safety data sheet. It tells you everything that's on it. The number one thing you can do is call poison control. Give them nothing to drink, especially if they swallowed it, because you don't want it to come back up, causes more damage. Okay. Now I always start by, if you're in the, when I started at the jail back a long time ago, we used to have people drink the cleaner all the time, okay, for whatever reason. And they would bring them down to booking, and they'd call poison control, and everything poison control, they would say it out loud as they're writing it down, and the inmate heard them, and now they have every symptom they'd already just heard off. So we don't want to make sure that they don't hear that stuff, okay, because they will have every symptom. When I first started at the jail, the jail administrator, first day I worked in the jail, he said, if somebody goes out to wreck and they twist an ankle, or you got to give them ice or whatever it is, make sure you add soap from the kitchen to their ice. I don't want them eating it. So that's what we did, right? Well, one day I did that, and the guy ate the ice and ended up on a vent in the hospital because he had an allergic reaction to the soap. So don't put anything in the ice. It's just ice. Let them eat it. And the one they don't talk about on here is seizures. You'll see seizures a lot. I'm sure if you're in the jail, you see them all the time. Some of them are real, some of them are fake. Whether it's real or fake, you can't determine. There's a few do's and a few don'ts, okay? Don't put anything in their mouth. Don't try to hold them down, okay? The things we do want to do is protect their head from bouncing off the floor, move them away from the wall, move everything out around them so they don't have nothing to flail on and hit them, all right? Once the seizure stops, then roll them in the recovery position, providing there's no injury, and just monitor them. Now, when do we send somebody to the hospital? If the seizure doesn't stop, or they have back-to-back seizures, we're going to send them out. If it's a pregnant female, I'm personally always going to send them out simply to make sure there's nothing going on with the baby. Other than that, unless they sustained an injury, I'm probably not sending them out for a seizure, okay? But that's a decision you have to make on your own as well. Does anybody have any questions? That's basic CPR or first aid.
When someone is unresponsive and not breathing or only gasping, it is critical to begin CPR right away. CPR consists of 30 chest compressions followed by 2 breaths. In this video, you'll first learn how to give effective chest compressions. Then, you'll learn how to give breaths using 2 different types of breathing barriers. And finally, you'll learn how to put together chest compressions and breaths to give CPR cycles. Compressing the chest and allowing it to return to its normal position moves blood carrying oxygen to the brain and other vital organs. First, ensure that the person is on their back on a firm, flat surface, such as the ground. If they are lying on a bed or couch, carefully move them to the floor. Next, kneel beside them like this with your knees near the person's body and spread about shoulder width apart. Place the heel of one hand in the center of their chest with your other hand on top. Now, interlace your fingers and make sure they are up off the chest. Then, position your body so that your shoulders are directly over your hands. Lock your elbows to keep your arms straight. This technique allows you to use your body weight to help compress the chest. You are now in the correct position to give compressions. When giving compressions, push hard and fast. Compress the chest to a depth of at least 2 inches and a rate of between 100 and 120 compressions per minute, or about 1 every half second. After each compression, let the chest return to its normal position. Watch as I demonstrate just a few chest compressions so you can see what they look like. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10. Giving breaths supplies oxygen to a person who is not breathing. Studies have shown that breaths in combination with chest compressions increase a person's chance of survival and minimize brain injury. The risk of infection while giving breaths is extremely low, and data shows you will most likely use your training for family or friends. However, a CPR breathing barrier, such as a face shield with a one-way valve or a pocket mask, can further lower your risk of infectious disease. These devices protect you from contacting saliva and other body fluids and from breathing the air that the person exhales. If available, you should use a CPR breathing barrier to give breaths. However, do not delay breaths to find a breathing barrier. While giving breaths improves the person's chance of survival, please remember if you are unwilling to give breaths, you can give compression-only CPR. This still helps the person and will be discussed later in the course. A face shield is a flat piece of thin plastic that is placed over the person's face with the opening over the person's mouth. It has a valve that you give breaths through without making mouth-to-mouth contact. First, place the face shield over the person's face, ensuring the one-way valve is over their mouth. This is the most important step when using a face shield. Then, open the person's airway using the head tilt chin lift technique. Put one hand on the forehead and 2 fingers on the bony part of the chin and tilt the head back to a past neutral position. Next, pinch the nose shut, take a normal breath and make a complete seal over the person's mouth. Then, blow into their mouth for about 1 second and make sure the chest begins to rise, like this. Allow the person's chest to fall and the air to exit while you take another breath. Then, make a seal and give the person a second breath. This is what it looks like put together. A pocket mask is a transparent, flexible device that can be sealed to the face, covering the person's nose and mouth. It has a one-way valve that you give breaths through without making mouth-to-mouth contact or inhaling air exiting from the person's lungs. First, place the mask at the bridge of the nose and then lower it over the person's nose and mouth, making sure it doesn't go past the chin. Now, seal the mask by placing the space of your hand between your thumb and index finger at the top of the mask above the valve, and your remaining fingers on the side of the person's face. Then, place the thumb of your other hand along the base of the mask and place your bent index finger under the person's chin. Lift the person's face into the mask and open the airway to a past neutral position by tilting the head back. Gently but firmly hold the pocket mask in place to form and maintain a good seal so air does not leak out of the sides when you give breaths. Now, take a normal breath, make a complete seal over the mask valve with your mouth and give 2 breaths. When you give a breath, maintain an open airway in the past neutral position, being careful not to push the head down. Watch as I demonstrate. Remember, each breath should last about 1 second and make the chest begin to rise. Pause between the breaths to allow the person's chest to fall and the air to exit. When giving breaths, the chest should begin to rise. However, you might encounter a situation where the chest does not begin to rise. If the chest does not begin to rise on the first breath, reopen the airway and give a second breath. If the chest does not begin to rise after reopening the airway and giving a second breath, an object might be blocking the airway. That is, the person may be in cardiac arrest due to choking. You will learn about caring for an unresponsive person who is choking in the choking module. Now it is time to put the skills you have just learned, giving chest compressions and giving breaths, together in order to give cycles of CPR for an adult. Each CPR cycle consists of 30 chest compressions followed by 2 breaths. Remember, it is important to begin each CPR cycle with chest compressions. However, if drowning is a suspected cause of cardiac arrest, deliver 2 initial breaths before starting CPR cycles. Also, make sure you smoothly transition between chest compressions and breaths. Interruptions in compressions to give breaths should be as short as possible, taking less than 10 seconds. Okay, now watch as I put chest compressions and breaths together to perform 2 cycles of CPR. 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 11 and 12, 13, 14, 15, 16, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. You should continue to give CPR cycles until you notice an obvious sign of life, like breathing, an AED is ready, another trained responder is available to take over compressions, EMS personnel arrive and begin their care of the person, you are alone and too tired to continue, or the scene becomes unsafe.
Is your policy they do full-blown CPR or can they do compression only? Do you know?
We do full blown.
Full blown, okay. So I just want to show everybody that if we're not going to do the breaths on the mannequins because I didn't put lungs in them because COVID's still out there. But I just want everybody to know if you're doing full blown mouth to mouth and you don't have a breathing barrier that has a one-way valve, whatever comes out of their mouth is most likely going to end up in yours, okay? Whether it be blood, vomit, body fluid of some sort. This is a pocket mask, just like she has right there. This valve will allow air to go in. Once you quit blowing air, it closes off. Whatever comes out of the mouth will not go into your mouth, okay? Again, they say the risk of catching something by doing mouth to mouth without one of these is minimal. So if your policy says you have to do it, I suggest you get one of these. Muskingum County, I have an ambu bag. We have 4 floors in the jail. There's an ambu bag on each floor. An ambu bag is a bag that's attached to this that gives the breath, that you squeeze and give the breath. So I just want to make sure you understand whenever you're giving somebody mouth to mouth, possibly you're going to have fluid in your mouth from them, okay? Okay, that's what I wanted you to see. The only time we're going to start with breath is you suspected drowning, Okay, obviously it's easy to suspect a drowning. You pull them out of the bathtub, swimming pool, river, whatever it might be. So I'm going to go over, there's a couple different techniques that you use. We've seen one on an adult. 2 hands in the center of the chest. Compressions are probably closer to 2 to 2.5 inches in depth. If you're using a mask, you hold it here, push it down. You want to move the adult head to past neutral position. Okay, and then 1 breath should last about 1 second. You should be able to give 2 breaths in 3 to 5 seconds. Okay, if you're doing straight mouth to mouth on an adult, you're going to pinch the nose, tilt the head past neutral, seal their mouth with your mouth, and give the breaths that way. Adult, 2 hands in the center of the chest on the lower half of the sternum. Compressions rate of about 2 to 2.5 inches in depth. Tilt the head of an adult past neutral. A cycle of CPR lasts for 2 minutes. Okay, so in that 2-minute time, you ought to be able to do 5 sets of compressions and 5 sets of breaths. So if you figure that up, that's about 30 compressions, should take you about 18 to 20 seconds. In a 2-minute cycle, you should be able to do somewhere between 200 and 240 compressions. Make sense? And when you transition from compressions to breath, it should take less than 10 seconds. Okay? If there is a second responder, one's giving breaths, one's giving compressions, Red Cross says that you should switch every 2 minutes. Okay? I'm going to tell you, you take longer to switch than it does to continue to do it. So my preference is do it until you can't go no more. Okay? That is the basics of CPR. I will show you the proper way. I'll do it on the table so everybody can see. Lock your hands, center of the chest, put your body over top of the patient, lock your arms, let your upper body do the work. Because once you start, they tell you not to stop until you become too tired. You can't continue, don't want to put yourself at risk. Obviously the person shows signs of life or EMS arrive. Okay? So it may be a long period of time is what I'm saying. So put yourself in a position where you're comfortable so you can do it. When we do compressions, we'll either do it on the tables or on the floors. I prefer to do it on the floor because it's easier. But some people don't want to get down on the floor. So however we decide we're going to do that. Okay? Any questions on how to properly do CPR? Now, AED. AEDs come in several shapes and sizes. If you don't know where they're located in the building, you probably should find out, okay? I assume you probably have 2 or 3 in here, I don't know. All right, and somebody on a monthly basis, according to your jail standards, should be checking it to make sure they're functionable. So the pads are not expired, the batteries are good, all that stuff. Number one thing, if an AED arrives on the scene and you're doing chest compressions, 100% of the time I recommend you hook it up. 100%, because you don't know if it would work if you don't hook it up. But the number one thing, turn it on.
Adult patient. If the patient is a child, press the child button. Remove clothing from the patient's chest. Remove packet and apply pads onto patient's bare skin. Apply pads as shown in the pictures.
So you heard that like 3 times, right? If you don't put the pads on, it's going to say that forever, okay? Every set of pads I've ever seen shows you where they go. Upper right side of the chest, lower left side. However, if it's a small child and you take a chance on them touching each other, one goes in the middle of the chest, one goes in the middle of the back. Will they work if you put the one that goes here down here, opposite? They will work, but they try to make it fail-proof. So, they say that every minute that you delay care or using the AED decreases the chance of survival by 7 to 10%. So basically you have about 10 minutes to get it hooked up is what they're saying. You should always remove any clothing, including bras for a woman, because they sometimes have wire in them. Wipe the chest dry. They used to tell you all the time to remove any medication patches. I still recommend you do that just because it could absorb some of it. They used to tell you to shave the person's chest if they're very hairy so you get a good seal. I already told you that every minute this is delayed decreases chance of survival. So I've seen people take off their shirt, it looks like they still have a shirt on, right? A sweater. What I do, because I do have a razor in every AED that we have at the jail, but I don't recommend anybody ever shave their chest because it takes too long. So when the pads expire, I leave them in with the AED. The new ones are hooked up to the machine, the old ones are there. Put them in place, rip them off, put the new ones on. If you don't have that option, some jails I go to has a roll of duct tape with their AED. They'll use duct tape to rip the hair off. If you don't have any of those options, put them on, get the best seal you can, and hope that it works, okay? Because you don't want to delay the care to be shaven. Will this restart the heart? The answer is no. People ask that. They have to have some sort of shockable rhythm in order for it to try to kick back into a normal rhythm, right? Also, I get a question all the time, can you use one of these on somebody with a pacemaker? You absolutely can, because what's a pacemaker supposed to do? Shock the heart, right? So that means it's not working. And where's most pacemakers placed? Right in this area. So you're not even interfering with the pacemaker. The other thing is you can use adult pads on a pediatric. They do not recommend that you use a pediatric pad on an adult because they say it's not big enough, they might not deliver enough shock. If you're the first person that arrives and you're doing compressions and you do not have an AED with you, when somebody brings it, they're going to hook it up while you're continuing compressions. However, if you're the first person there and you have the AED with you, hook it up before you start and then let it tell you what to do. It'll start analyzing immediately and tell you when shock's advised. As soon as the shock's advised, it'll tell you, obviously they don't regain consciousness or their heart start working normally, to go back into CPR.